So this is the final Health and Wellbeing Board of the municipal year. So I want to thank you all for your input over the year, and obviously we will look forward to next year. But before we start today, I want to make sure that you are aware of some of the housekeeping matters. There's no expected fire alarm today. So if the alarm sounds, please exit by the nearest exit, and we gather outside near the law courts, that sort of side of things, so we're well away. This meeting will be broadcast live to the internet and will be capable of subsequent repeat viewing. By entering the Warspite room today and during the course of the meeting, committee members are consenting to being filmed and to the use of the recordings for webcasting. Can I ask that you speak clearly, directly into your microphone when addressing the meeting, so the online participants and the public can hear, and that you switch it off when you're not using it. And your mobile devices should all be turned to silent, please, she says, quickly checking. So, Elliot, apologies for today.
Thank you, Chair. We've received apologies from Gary Wallbridge. Stephen Beat is deputising today. Apologies from Professor Bob Fern. Laura Alexander is deputising today. Apologies from Mark Hackett. Rachel O'Connor will be joining us later online. Apologies from Michelle Thomas, Stafford Jones, Matt Garrett and Tracy Lee. Thank you.
Thank you very much indeed. Do members have any declarations of interest in regards to today's agenda? No. Right. I would like to go around and everybody introduce themselves, because there are a couple of people deputising and everybody might not be aware of them. I'll start this side to give chance for you to settle in there. Vice Chair.
I'm Councillor Cathy Watkin. I'm a councillor in Plymouth Radford Ward.
Thank you. Councillor Mary Aspinall, as I say, our Cabinet Member for Health and Adult Social Care. Welcome.
Steve Madden, Director of Public Health.
Elliot Werngle, Democratic Advisor to the Board.
David Haley, Director of Children's Services in the Council.
Rob Smith, Chief Exec of Improving Lives Plymouth and Chair of the Health and Wellbeing Hubs.
And it doesn't demean your presence here by having to share, sorry.
So we work collaboratively, don't we? So morning, I'm Chris Morley. I'm the Locality Director in Plymouth for the NHS Devon ICB.
Tony Gravett, Health Watch Devon, Plymouth and Torbay.
Morning, I'm Stephen Beat, Head of Adult Social Care, Plymouth City Council, subbing for Gary Wallbridge.
Laura Alexander, Head of Health Partnerships at the University of Plymouth, subbing for Bob Fern.
Thank you. I'm Councillor Jemima Lang, Deputy Leader of Plymouth City Council. I am the Cabinet Member for Children's Social Care, Culture, Comms and Legal.
Morning, Councillor Patrick Nicholson, Leader of the Independents and represent Plymouth and St Mary Ward.
I'm Karen Pilkington. I'm representing POP and Matt Bell.
Thank you very much, everybody. That's very useful to be reminded. Right, so we've had no questions from the public, have we? And those of you that were here last month know that we did have a question, and you'll notice it's in the minutes from last time. So going on to the minutes, those of you that were here, are you happy that they were a correct thing? I found a couple of typos, so Elliot and I will sort that out afterwards. I'm going to make him write them all out again, you see, so before I sign them. But there were a couple of typos. Did anybody else pick up anything? No? Lovely. But if once that's been sorted, you're happy that I sign. Thank you. All right, item 5, no, as I say, no questions from the public today. And comes to item 6, which is the One Devon Joint Forward Plan. And we welcome John Taylor to the meeting. And the floor is yours, John.
Morning, Chair, morning, members. I'm just going to share some slides. Here we go. So, what I'm presenting to you today is the update to the 5-year joint forward plan. You should have a copy of the plan as Appendix 1 with the report, so hopefully you've had a chance to review it. Joint forward plans are 5-year mandatory plans for integrated care boards. They set out primarily how the integrated care strategy is going to be delivered over a 5-year period. And the integrated care strategy is the integrated care partnerships strategy. They're designed to be public-facing documents, and they set out how ICBs and the partners will meet the health needs of the population, deliver NHS universal commitments, and deliver ICB statutory duties, and also address the 4 purposes of ICSs. NHS England's operating planning guidance this year set out that we needed to do an update of our joint forward plan, and we need to publish this before April. Locally, it's been agreed, and it's in line with the national guidance, that this year's update should be very light touch, for 2 reasons. Firstly, the integrated care strategy, which the joint forward plan is intended to deliver, is not being updated this year. It was put together in 2023 with a lot of extensive engagement work, and actually is still very relevant to the challenges that we're facing at the moment. Secondly, we're expecting the NHS long-term plan to be published soon, probably in the spring. And of course, when that comes out, we will significantly have to review the integrated care strategy, probably a significant update next year, and that will mean that we then need to update our joint forward plan. So with this in mind, we want to keep it fairly streamlined and light touch this year because of the kind of strategic context that we're working in. So just a bit of a reminder, particularly for new people on the committee, the 12 challenges which you see on the left of the slide here, that was kind of the basis of the case for change which informed the integrated care strategy. And you'll probably note that a lot of those challenges remain things that we are grappling with today, and they're still highly relevant. On the left, you've got a summary of the integrated care strategy, which, as I said, remains the same this year and isn't being updated until next year. The plan last year was structured around 3 categories: so these healthy people, healthy safe communities, and healthy sustainable system. And this kind of structure to the document is remaining the same this year. What has changed this year, and we've taken the opportunity to update the bits where relevant, we've updated the document to align better with the NHS Devon annual plan. We have taken account of the NHS operational planning guidance, which sets out the priorities for the NHS this year, so some changes to targets, trajectories, and other significant in-year developments. We've also updated it to align with the latest medium-term financial plans for the NHS and local government, and we've got a statement from each local authority just on their medium-term financial plan alongside the NHS statement. We've also significantly updated the governance section because that is an area that's developed through the year. So the integrated care partnership hasn't been meeting regularly over the last 12 months and is currently going through a bit of a refresh, so that's reflected in the document. We also have a system leadership group which wasn't in place last year, so that's described in the document. And then local government content, such as the Health and Wellbeing Board statements, will also be updated and refreshed. So each section of the plan describes, very similar to last year, so it describes the ambitions and objectives for that particular work stream, the difference that delivery of the plan would make for the people of Devon if it's delivered by 2030. It sets out the achievements over the last 12 months, so it gives a bit of a flavour of progress over the last 12 months. And it also sets out which of the ICS aims the work links to, and that provides a bit of golden thread throughout the document. This slide is, it's tricky to see, certainly with my eyes, but this is content that's in the document that you've got Appendix 1. And it sets out what Devon will see in 2030, so it gives you a bit of an idea of the outcomes of the plan. And you can see that in Appendix 1 in more detail. And we can share the slides for people if you can't quite see the content. So next steps, we need to take the joint forward plan to our NHS Devon board on the 27th of March, so we're preparing for that. It then needs to be submitted to NHS England for a review before it's formally published in April. So the recommendation today is we want to, as we do every year, and as we have done for the last couple of years, we want to get the Health and Wellbeing Board just to endorse the plan to assure us that it still aligns with local health and wellbeing strategy. So I'll stop sharing there and open it for any questions.
Thank you very much, John. Any questions from anybody having read through the document, as you all have? Thank you, Patrick.
Thank you very much, Chair, and thank you, John, for making the presentation. Good to see you. If I could just pick up on sort of one area around urgent care and discharges, because clearly the NHS are saying that the vision is to ensure more community-based support, and clearly bed blocking is often because there is a lack of capacity in the community for people to be moved from an acute setting for ongoing care in the community. Just, I'm going to be very specific, because as the health service is operating today, they're making decisions that would have an impact on their ability to improve and expand community provision. So I have, within Plymouth and St Mary ward, an old care home that University Hospitals Plymouth purchased during the COVID pandemic as a step-down facility, yet it's now up for sale because there's a change of direction. So in relation to the plan, John, you might not be able to answer this, but in the context of the plan, what's the health community doing to safeguard future opportunities of expanding community provision by making decisions, sort of short-term decisions now, perhaps on assets that currently exist as health service facilities? Because clearly there's an aspiration to expand community provision, but a sale of an asset now might prevent that ability to expand in the next sort of 2 or 3 years. Thanks.
If I just answer the kind of strategic bit and then direct to Chris. So I think in terms of out of hospital in general, I think one of the updates that we've made to the joint forward plan this year is kind of off the back of some discovery work that we've done in the out of hospital space. So it's a real priority for us, and it's going to feature significantly in the strategy that is developed next year, particularly when the long-term plan or the NHS 10-year plan comes out. I think on the specifics, and Chris, do you want to come in?
Thanks, John. So certainly in terms of the hospital discharge space, it's something that we've had a huge focus on in Plymouth, and we've spoken previously around our focus being very much to support as many people in their own home. So whilst there were units and we had bedded provision that we were growing at one time, our focus is, certainly over the last 18 months, has been to grow the number of people who go home and the amount of support that we have in terms of care workers and reablement workers to wrap around those individuals, because we know those outcomes are better. And we've seen a 120% increase in the proportion of people that go home. And that's meant, as we've revisited the demand modelling that informed some of the decisions that we made previously, it's enabled us to make some of those decisions. So I absolutely agree, Kirsty Nixon, around the need to ensure that where those decisions are being made, that it aligns back to the strategy. I think that's the importance of the integrated care strategy and the joint forward plan, in kind of knitting all of that together and just making sure that from a Plymouth perspective, that reflects the local population need that we've got.
Joe, can I just come back? I appreciate both responses. I don't know if this is something perhaps the board could look at specifically in a work item, perhaps for the next municipal year, Chair. I think it would just be useful to drill down a bit more because, certainly I had a lot of instances recently of family being in the healthcare, being in Derriford and actually seeing the volume of older people. And I just happened to go on the results of the last census, and the population growth of old people in Plymouth is horrific. So whilst that might be the aspiration, Chris, and I totally accept your professional opinion, the reality is there's a lot of old people that never go back to their homes. And I've got an aunt now who's currently at Mount Gould. She won't return after having had a severe stroke. She'll have to go into a care setting. And my concern is that decisions are being made every day that potentially remove the ability to perhaps use assets that are being disposed of. And I just think if we could programme that for the next municipal year, it would be useful just to put facilities and the numbers together so we have a better appreciation. Thanks.
In fact, that's something that goes quite regularly to health scrutiny for them to look at. And I think things have changed over the last few years. I think whilst there always will be that case that somebody may well need to go into residential care or nursing care, the aim is to get home first is the absolute choice because people do much, much better in their own homes. So I think whilst I'll talk through with Steve as to whether it's appropriate for here, but if not, we will ask if adult social care scrutiny will take it on. But
Thank you very much.
we do every year look and see what we need and then commission what we need. So I think that, it's not something that we do it 1 year and then it gets forgotten for 5-10 years. So I think please be reassured that that balance is happening. Stephen, do you want to come back on this question? Then I'll go to Jemima.
Yes, just briefly from an adult social care perspective, we do support a significant number of people in care homes. We try wherever possible to plan people's care in advance of them reaching a crisis and being in hospital. But obviously in some cases, someone has a severe stroke or something and they can't return home. So there are certainly people who do move from hospital into more permanent care home type support through a discharge to assess arrangement through what we call a pathway 2 or a pathway 3 bed where they would receive some rehabilitation. But as Chris and John says, our focus is always to try and support people to go home, even if it's for a period before they can then plan onward care arrangements.
Thanks very much. Jemima.
Thank you. I've been talking in other forums a bit about this kind of my concern and other people's concern about the kind of COVID generation, so the children born in 2020 or thereabouts, and I just feel like it's a bit of a missed opportunity to not have, COVID, uptake of immunisations and things like that, it's mentioned, but a focus on that group of children. And we know we've talked about dentistry, their dentistry needs in other places, and immunisation, health checks, all those things. I just wonder how we can make sure that any extra impact that COVID has had on that group of children who are coming up to 5 now is going to be addressed sufficiently in this plan.
Yes, I think with the review, with a significant review of our strategy next year, there will be an opportunity to get into some of that. Obviously, as you mentioned, there's stuff in the plan there that's relevant to that. But we will do kind of pretty extensive engagement over the next year. And I think, as you say, if they're coming up to 5, it would be a good time to get some input from people that know that group, yourself, others in the children's space, to really make sure that that's recognised in the update to the strategy next year.
David?
Thank you. I welcome the section in the report on children and young people. It's good to see that there is a section there on some objectives and priorities, and I am well aware that there is more extensive work that is being undertaken within the ICB in relation to a more detailed and specific set of objectives and actions for children and young people across across Devon ICB, and I would just confirm to Plymouth's Health and Wellbeing Board that Plymouth are well engaged with that work, with colleagues like Hannah Pugliese, for example, who is leading that. A couple of comments in relation to the priorities. Again, it's good to see the achievements in relation to the additional capacity within the multi-agency safeguarding hub, and how that continues to strengthen its work in a multi-agency partnership space. I would just reference, and it may be helpful to bring back at the appropriate time to the Health and Wellbeing Board, the government's new reforms under the Children's Wellbeing and Education Bill in relation to how partners will are being required to work more and more together and more strongly together in that space. So that may be something for a future agenda and forward plan. And also in the notes, the reference to the work around special educational needs and the delivery of the local SEND plan. A couple of things that I would welcome further consideration of is in relation to meeting the health needs of our children in care and care leavers. So there is an extensive action plan and work programme which currently reports into the Corporate Parenting Board, but we do have some challenges and issues around, Councillor Lang's mentioned immunisations in a separate context, but immunisations, dental checks, initial health assessments, repeat health assessments, etc. And we're monitoring all of that work very closely. So some join up between that and this in relation to a priority for that particular group would be really helpful, and show that join up of work across different governance and work streams. And secondly, in relation to the delivery of services, in relation to, for example, our family hubs, our health and wellbeing hubs, the government, clearly through the new reforms from children's social care, and on the adult side, the reforms for the delivery of NHS services, although we certainly need to and have started conversations with health about the implications of that for children too. There might be something here in sort of weaving that across in relation to children and young people as well, about how we start to develop that locality-based working within communities at that very local level. Thank you.
Thank you. Stephen?
Thank you. I really like this document. It's very public healthy, so it makes me smile a lot. I'm really interested in the healthy, safer community section. We bang the drum a lot around recognising how the wider determinants have an impact on health and the need for healthcare services. I suppose in relation to the housing and employment sections, it's just a plea to make sure that there is really good joined up working, because obviously multiple partners are in that space. What I didn't necessarily see was the strong emphasis on the role of engagement with local authorities, particularly in the housing space, because it talks about generating a lot of referrals in the voluntary sector and other partners, but recognising where the statutory functions sit around the delivery of housing. So it is about trying to understand need and manage expectation, because we're all in some form of housing crisis. But it's really great to see it in there, because it really does highlight the impact on having clean, safe, secure homes for people to live happy, healthy, long, independent lives. Similarly, around the employment, I suppose the proof will be in the operational plan that sits underneath this, but it's really great to see that it's recognising, again, the role of employment for keeping people healthy, but also getting people that haven't been in employment for a really long time to get them back into that space. Economic inactivity will cripple the country if we don't address it now. And we know we're on a bit of a slippery slope as we head towards 2040. So anything we can do as anchor institutions across the system to address that is really key. I won't touch on the suicide prevention, because I think that's a really good example of partnership working. So, and it's on the agenda today, so I won't talk about it too much. The other thing that I think is just missing is around the health protection. So again, it's really great to see that health protection is reflected in in the plan. What I think is missing is a commitment to looking at how we join up the health protection system. In my opinion, it's quite fragmented at the moment. We have multiple partners in that health protection space, but there are gaps around how we respond to health protection emergencies. So it would be nice to have that acknowledged through the report as well. Thank you. But really great report. It was a lovely read. Thank you.
Thanks very much. I'm just going to jump in here as well. There's a couple of bits and pieces that I feel we're missing from it. I know there's been a huge development on the frailty service, and I think that would be really useful to make sure that something about that goes in, because Jane and the team have done a huge amount of work. The other thing, I'm sure you won't be at all surprised, is that I really want the dentistry side of things bumped up. I think waiting for another 2 years is not acceptable as far as I'm concerned. And I'm sure Jemima will share that view as well. So there's that. And again, it's funny, isn't it? We've all got our ways of marking things, and I've been turning down corners on this because I've forgotten my little sticky thingies. And again, I'd put down about working with local authorities a little bit more about housing, etc. So, and I think what I need to say to all of you is that I'm actually at that meeting on March the 27th, I think it is. So what I think I'd really appreciate is some conversations with those of you that have made comments before I go up there, so that I can put those points over firmly, shall we say. But yes, it's essential to do this refresh, isn't it? Patrick, come back to you.
Thank you, Jo. I wanted to pick up on Steve's point around housing, and you've just touched on it as well. And this is really to help health providers. So a number of years ago, the City Council, really I think probably through me raising it as the then Cabinet member, looked at the health contributions from developers under Section 106. And I've recently attended the Audit and Governance meeting of this council, and also we all as councillors attended the budget meeting. And in the medium-term financial strategy, it set out the requirements of the capital programme for the council. But just for everybody's awareness, only 3% of the capital programme comes from developer contributions. Now, from experience, and Councillor Watkin would bear this out as a member of the Planning Committee, the contributions from health are minuscule compared to affordable housing requirements, highways and other developer contributions. And I just wonder, in the reforms that government are now doing of the planning system, that the health community at large should be asking government for greater developer contributions to health infrastructure. You know, why should, effectively, it would appear that either the health community recycle assets or you get money from government. You really ought to be getting substantial contributions from developers, and clearly with the housing agenda that the current government's got, the growth agenda that we've collectively had in the Plymouth area, you know, it's just, I would suggest, totally inappropriate and insignificant the amount that health gets from developers. So I'd urge perhaps through this plan or through other partnerships that we raise this as a strategic issue, both with Devon and you know, collectively with Devon, but for Devon to raise this with government, because it would be one way of trying to resolve some of the funding deficit that currently exists in the health service provision in our county. Thank you.
And certainly we can look to Plymouth Housing Task Force as well to help us with that as well. So again, Stephen, perhaps a conversation about that before I go up there. Rob, any thoughts? I mean, it mentions the voluntary and community sector in here. Any thoughts that you want to add?
I suppose we've been reassured in terms of conversations with across the local authority with public health, with the ICB around the approach around community-based preventative services and the emphasis. As you know, we've been heavily self-organising within the voluntary sector, particularly around the wellbeing hubs, looking for very close relationships with Live Well around how we can ensure that we co-design integrated services at a local level informed by local community needs, working with colleagues in POP and more broadly across the sector. So I don't know how well articulated it is in this particular plan, but there is certainly strong evidence in terms of local planning involving the voluntary sector and local community sector and how it integrates upwards and vertically and horizontally.
Excellent. And certainly from my conversations with the ICB, they certainly value Health Watch and the input that they get with working with you. So, oh, good. I'm so pleased.
More to come, I think.
I think you're probably right. Yes, Tony, you're not going to be able to sit quietly, I don't think, by any means. Okay, folks. Seems to be the ends of hands up, etc. John, thank you very much indeed for coming along today. We really appreciate it. And as I say, I'll get some of the team around me, so at least I've got some ideas to bring up. So on the 27th, that's good. Thanks very much indeed. All right.
Yeah.
We know what I need to do now, folks. Because I can see a piece of paper coming towards me quick if I don't. We need to endorse the updated draft forward plan for 25 to 30 and confirm it aligns with the priorities identified in the latest health and wellbeing strategy. Are you all content?
Just a quick one, Chair. So I'm content to agree the recommendation. Are we going to capture somewhere in the minutes some of the salient points that came out of the discussion so that we know that they're going to be taken? Yeah, lovely. Thank you.
Yep, Elliot has been taking notes, definitely. So we won't lose that. So are you all in agreement? Yep, nobody dissenting? Right, thank you very much indeed. Chris, the floor is yours.
Thank you, Chair. I've got some slides. Elliot, I don't know if you can help me. I'm trying to get into the room to share them on the screen. Okay, so talking this morning about neighbourhood health services and the development of them within Devon and Plymouth. It's quite an exciting opportunity to be coming to talk about this today. It's an area and an agenda that's been under development for a number of years, and more recently as part of the planning process and the suite of documents that have been issued as part of that process that the NHS undertakes each year. The neighbourhood health service development has been a key component of that. So purpose of the conversation today really is to give the board an overview of what neighbourhood health services are, what some of the guidance is saying that's coming out, and then what some of the opportunities are within Plymouth, and where we might want to think about how we shape and influence that agenda as it evolves within the city and within Devon as a whole. So at its heart, what the neighbourhood health model is about, it's all about bringing services together, joining them up in the community in a much more effective way. The focus initially, you'll hear a bit more about as I talk through the guidance, describes people with more complex health and care needs, but actually that's should be across children and adults and a broad range of services that people access. Really, really important and central to this is about how we improve health and wellbeing, focus around avoidable pressure on health, social care and other services as well, and how we develop our offer around that. And really, really key to that is how we ensure those close partnerships that exist between the NHS, local government, social care providers, our voluntary and community sector providers are all working together in order to support those individuals, family, unpaid carers, etc. I think where Plymouth has a real advantage at the outset of this is the strong community assets that we've got in place and some of that joint working that's developed over a number of years. Nationally, there's some great examples of local integration and collaboration, and the focus this year is very much around how do we take forward some of the development and look at what the opportunities could be, but not starting afresh, starting from the point of understanding those assets already got within and how we can take those forwards in terms of configuration and support in order to wrap around some of the key components that I'll talk through the model as we go through. So the guidelines themselves that have been published, they set out a framework for how systems can move forward with a community-centric model of healthcare delivery. It's very much centres on the 3 strategic shifts that were announced some time ago for the NHS and form the basis of the engagement that's taken place around the development of the 10-year plan. So the movement from acute to community, so this is very much about how we have services that are centred within community neighbourhood level. Moving from analogue to digital, so making the most of digital opportunities as part of that, and a really strong emphasis on prevention, so moving away from sickness to prevention as part of that. The guidelines that have been published are very short, but the idea with them is they set out some kind of key components, but it's then over to local systems and local partners to build services and develop the offer locally that best responds to the local need and recognises where we might have infrastructure and relationships already in place. There's some support that's being offered through NHS England, the regional teams. So the idea with this year is very much about setting the foundation for the development of the model. But there will be a national implementation programme that will support areas, and there's an opportunity for one area within each ICB to be part of that implementation programme. So that is something that Plymouth as an LCP or Health and Wellbeing Board area might want to consider, whether that's something we would want to raise back into the ICB. There's an ask that's come out, as I say, this was all part of the suite of documents that informs our annual planning, operational planning process within the NHS, but a letter too that came out to the chief executives of the local authorities asking them to engage and support the development of this moving forwards, but recognising and starting with a focus initially on those individuals with the most complex health and care needs. We'll get some more detail in terms of what the national programme looks like over the coming months as more and more details are prepared around that. I would say there's a really strong line as well, the Better Care Fund, which the Health and Wellbeing Board oversees. The planning requirements for that next year have in the development of integrated neighbourhood health services front and centre. So there really is an expectation that development of our plans are investments around that support the delivery of this in gender as well. Within the guidance, there's a 5 to 10 year vision. Again, this is quite high level, recognising we're going through the process of the NHS 10-year plan development at the minute and the engagement around that. But as you can see, it strengthens very much and builds on those 3 core shifts and that move to support people at home in their communities where it makes sense, and supporting that much greater engagement across services. The model describes 6 core components that are key to the delivery of an effective neighbourhood service at a high level. So the first one there, you can see population health management, so having a data set that brings together information and intelligence across systems and partners with a system that enables us to then take from that and use risk stratification models to understand where there might be particular population health needs in particular areas. We've got that through the One Devon data set across Devon, and so very much in terms of thinking about how we utilise that and take that forward and capitalise on some of that would be key in this. General practice fits front and centre as well, so making sure that the modern general practice model is in place and that we're streamlining care and making sure we're shifting more to that proactive approach alongside our general practice colleagues. Standardising community services, so again there's been publication of guidance around supporting this to make sure that we've got the right focus around the priorities that are needed for the commissioning of community services and strengthening that as part of the offer. Similarly, the links across to other parts of community provision as well. It's both mental health as well as physical health, but also linking with the voluntary and community sector as well. Neighbourhood multidisciplinary teams, so that's particularly in thinking about an initial focus on those individuals with the most complex needs. How do we have a team that can wrap around those individuals with a case management oversight support for each of those individuals, care coordinator who's their clear point of contact, but then how they interface with more specialist services. Integrating intermediate care, so again we've spoken already today again about our home first approach and how we're supporting more and more individuals at home where they need additional support, be that as part of a step-up process where they've needs have deteriorated and they need additional support in order to keep them out of hospital, or where it has been necessary for somebody to go into hospital, how we step them back down in a quick way that brings them back into their community and then wraps those services around them. And then the last point on there, urgent neighbourhood services, so a real focus around how do we strengthen our urgent response, the range of different offers that we have in place now within Plymouth around hospital at home, virtual wards, and the urgent treatment centre like the one at Cumberland and the on-site one that's being developed at Derriford Hospital, how we bring those services together with a focus on where individuals have a greater level of need, we can support them in a place that avoids hospital where that only becomes where it's necessary. And then also building on the work that we've already got through our care coordination offer and the Gateway Hub within Derriford that acts as a point of contact for paramedics and other clinical decision makers who might be considering a need for somebody to go into hospital, that they can access the support of professionals who can then guide them into the best service before a decision's made to bring them into the hospital. So I think important to recognise, as I say, that kind of gives us some starting points around the principles that we should be applying when considering neighbourhood services. But that's why I do think within Plymouth, Devon as a whole, but particularly within Plymouth, there's already a really good platform that we can start to think about how we build upon. In terms of what the guidance sets out then around the delivery that needs to take place in the year, summarise some of the key points there on this next slide. As I mentioned, the focus and the ask initially is around those individuals with the most complex needs, which on a national level makes up about 7% of the population, but actually the real suggestion that we narrow that down to think about those cohorts within that where there's the greatest potential to improve independence and where that might free up resources that it then enables us to focus more on prevention. That recognising there's already lots of best practice that we can take from thinking about things like the single electronic health and care record, and there's a great deal of work that's been done within Devon around looking at how we can bolster that service, bringing together patient records and information across services where we've got different organisations holding records and how that can help with our approach. The process, it will evolve, and so a real recognition that we need to trial some of this and evaluate that and go through that planning and learning approach to do that on a continuous basis. And a real focus around healthcare inequalities, so using our population health methodologies and thinking about where we've got particular inequalities within service provision, actually how can we do this in a way that recognises and responds to some of those challenges that we face. And then some of the critical elements that we need for that implementation, so that strong senior leadership in place to drive this integrated working, and I would suggest the board that would perhaps think about how the Health and Wellbeing Board can support in that place alongside the local care partnership within Plymouth, having that clear set of shared values and objectives that we want to move forwards, and really using the opportunities that we've got around some of those pooled funding arrangements. And again, I think that's the link back to and the opportunity with our Better Care Fund and how we best utilise that money in a way that can support us with the development of these services. The last slide there just talks about some of the work at a Devon ICB level and ICS level. So the guidance has come out, as I say, centrally to NHS Devon. Where we've started to take some work is the establishment of a steering group to develop a roadmap for what the development and delivery of the services look across the whole of Devon, but absolutely recognising that this needs to be driven at a place level. It needs to be driven within Plymouth in our case, and I think that's where the Health and Wellbeing Board, the Local Care Partnership, Local Authority and the other partners who sit on this board too have a real strength and opportunity to help us in working collaboratively in order to shape that. What we've started to do though is undertake a self-assessment against that guidance. And we're doing that through the Local Care Partnership initially, just to understand for each of those local care partnerships within Devon, what do we already have in place against those 6 core components, and also start to identify some of those local assets that we might have, so things like the hubs in Plymouth, some of the other community development offers and things like that as well, alongside some of the more traditional services, just to start to set some of that out. So I hope that was helpful in terms of giving a high-level overview of what it is. As I say, the guidance is intentionally high level in a way that enables us to shape that, but we'd be really keen to hear the board's thoughts on actually how we can support that as a local system and best take this forward.
Thank you very much indeed, Chris. Anybody got any questions? Right, I'll start from this end. Karen.
Yeah, so within our community, there was an address that was receiving over 100 calls to swear like per year. So that person, we know who's in that address. So they've been helped extensively by the community hub, and that's going down. But I'm just wondering how this work is captured, how all of the community hubs who are doing this kind of great work are being supported. I'm thinking financially about that as well, with some of the larger ones and some of the increases in April with minimum wage and employers NI, and how the community can be better supported to do that kind of grassroots support.
Thank you, Karen. So absolutely recognise the value of the work that the hubs are doing and the impact that's having in a very, very real time in terms of supporting some of those individuals. I think you're absolutely right. We need to make sure that we're capturing some of that great work as we take into this. This isn't about starting from a blank page. It's about recognising those assets and those offers that we've already got in place. The ICB does make a contribution towards the hubs through the fair shares money, and that's something we're very committed to in terms of how we support that. I think it's worth recognising that the development of this doesn't come with any new cash, unfortunately. That would be wonderful if it did, wouldn't it? But it's about recognising what we've already got and how do we bring that together in a way that enables us to work differently moving forwards and strengthen those things that are already there.
Patrick.
Thank you, Chair, and thank you, Chris, for the presentation. I think it's a really exciting agenda, isn't it? Because speaking as a local councillor, I think there's a huge deficit between the public at large and all the good work that the health partners are delivering on a day-to-day basis. And I'm hoping this might actually start to bridge some of that, I don't know what the right word, it's not distrust, but people are not satisfied necessarily in the community with what they're receiving from the health service. And to logic, that some of it's perception, it's not the reality. Because when the reality is that you need to use a system, the system does generally respond. You know, it's not perfect, as we all know, but within the limitations of the money available, generally you get a response. My question really is probably more to you, Chair, and the councillors. How can we influence the council's participation in the process by engaging our own communities and trying to assist in the mapping of the neighbourhood provisions that, you know, can be very different even in the city context. The needs in, say, Devonport may be different to the needs in Plympton or Plymouth. So how can we have that conversation from a council perspective? Because I think it would be really useful to influence those who are participating on behalf of the council with some very real sort of local focus, but also to use the opportunity of this exciting agenda to try and bring the public more in line with the direction of travel for the health service and our health outcomes in future years. Because I think this would be a really great opportunity to do that. And my only final point, Chris, at this stage, do we know in the longer term what sort of money would come with this agenda from government in terms of the, you know, the indications from the Chancellor's budget?
Do you want to take the money bit, and then we'll take the other bit in a minute?
So at this stage, there isn't any indication that there's any new money attached to this. But I think in terms of thinking and understanding around it as we shift more to prevention, how we can free it. You know, we are in a very challenged financial position, but understanding the benefit and the value of that, I think that's where if we can start to develop some of this and demonstrate the benefit, then that will help us.
Thanks.
Do you want to come in about this bit of it, Rob?
Yeah, if I could please, in relation to the last 2 points, in terms of support for the local community to be able to articulate and become involved in terms of supporting the wider initiatives across the city. Obviously, we do have the community builders team working at a grassroots level in those communities, and they're focusing in those communities where there's no wellbeing hubs. Whether there are wellbeing hubs or family hubs, they're excellent facilitators of conversations to be able to feed that information back into the system. So I would definitely recommend you make connection with the local community builder and the local wellbeing hub. In terms of the funding point of view, just to let people know as a matter of interest, the wellbeing hubs, we've got 11 in the city operated by 9 organisations now. The majority of them just get a flat rate of around about £25,000 a year to facilitate as a wellbeing hub, so it's not a specified service. It's a little bit of seed money, if you like, in order to support them act as a gateway to services. And some of our hubs actually don't receive any funding whatsoever. And we operate 2 hubs. We only get half funding for our second hub. So it's up to each hub then to individually curate its own range and breadth of services to be able to support needs on a local basis, and they can differ quite significantly. But we know that there isn't much money in the system. We understand that. So it's how can we reorganise and integrate the existing resources to use them more effectively. And that's where the ability to sit down and co-design services with the voluntary and community sector in the first instance, before we go too far down this planning directive from above, is absolutely key and critical for us, because we're often left on the sidelines, because a lot of the presentations we hear just at times just seem overwhelming. So our own organisation, we've got 2 buildings, we've got only 80 members of staff. So you can imagine that as a chief executive and trying to keep across public health, adult social care, community pharmacy, dental services, PCNs, the hospital, all those wider social determinants in health. And at the same time, you know, when I go back into the office, I'm going to be having someone grabbing hold of me talking about the roofs, you know, leaking again, and the toilets blocked, and there'll be some type of major disturbance in the foyer because someone's so stressed in terms of their mental health, or that they're about to be kicked out of their house. So the ability for the community sector to really engage with the wider statutory agencies is absolutely critical. I suppose what's the point I'm making here? I'm reflecting as I hear a lot of the discussions around strategy and some of the plans, just how overwhelming it can be, and it seems we can get lost into discussing about. I should have Gary Wallace here today. Actually, sorry, Gary. But it's understanding the framework of the planning and the way that management's undertaken within the statutory sector, and how it's overwhelming it can feel for smaller. Well, not small. Yeah, just community organisations not involved in that on a day-to-day basis. And yet I do think we do have potential for a lot of the answers. So it's how we can better, I suppose, support the sector to engage with strategy in order to be able to inform services and keep the debate sometimes quite real in terms of the narrative, in terms of people's lived experience, which is absolutely critical. It just feels at times, the conversation just feels so dry, so managerial. We just seem to lose the essence of what we're here to do sometimes. So it's about getting the balance right, I suppose. Sorry, that's a bit of a ramble.
No, Rob, that's fine. And in fact, if you watched last time's Health and Wellbeing Board, Zoe Sydenham came and gave her report about community builders and about community hubs, etc. So it would be worthwhile going back to that, and obviously have a dialogue with Zoe as well if there's some points you want to raise. And of course, we've got Stephen, and in fact Ruth was very much involved with some of the hubs, etc. So it's our staff that have been and officers that have been working hard with them. So I think, to me, it's amazing what we've achieved with those hubs, and Zoe very clearly points out how many people are attending those and various services, etc. So it's worthwhile having a look at that as well.
Yeah, apologies. I had a work commitment, that's why I couldn't attend last time, but I'm more than happy to look it up. You know, certainly very recently I did go into the Reese Health and Wellbeing Hub, which serves my area, and see the good work they've done. So if that's the area to go to try and sort of simulate greater debate, all I would caution is that the percentage of the population that use them is probably quite small. So therefore we just need to take that into account. And I just think at times, you know, a massive amount of the population are interested in healthcare. So a lot of them are disconnected between all the good that's going on and we hear about in these forums against the reality in the street, because probably those people, again, their perception from the television and from news, you know, and comment rather than perhaps the reality. So thank you for that. I'll look into that, Chair. Thanks.
And I think really using them as warm spaces as well has really made a difference. So I think those people that perhaps wouldn't have gone to them have been going to them, and it then becomes that, oh, it's Wednesday, we'll go to wherever and have a coffee and a chat. So I think that's really helped how they've been established, I think. Did you want to come in there, Stu?
Yeah, I think it's just building on what Councillor Nicholson has said, is that I think I recognise that there is probably more we need to do around engagement in the broader elected member space around this. Not to reiterate all the points that Rob's already made, because I think they're really good, but it's about how we work more. We do have to work more strategic together, and I recognise that through the Thrive programme that we're very good at coming together as a network, but actually we're missing some of the governance that actually drives some of this work forward and helps to navigate those points that you make, Rob, around the complexity associated with strategic functions and everything in between. The real ambition, which is great in relation to neighbourhood working, is that I think Plymouth's already in a really good place, and the points that Rob's made around every health and wellbeing hub is nuanced and different, not just because it's delivered by multiple organisations, but it's really adapted to the needs of the community. And I think there is a real opportunity for this broader neighbourhood working to harness on that without losing the original ethos of why they were put in place. Some of them have grown a little bit in a strategic direction, some of them have been a bit more organic, and I think we need to just wrap a little bit more framework around that and get local councillors involved in those conversations as well. So I'll take those points and we'll take that forward as well. Thank you.
Okay, Jemima, did you have your hand up?
Yeah, it's kind of, Councillor Nicholson sort of covered it, but just in terms of communications and communicating to people, you know, I might be wrong, but I would assume that some of the people who would most benefit from utilising the services there and just walking through that door probably don't think it's for them, maybe don't know about it. So I think for any initiative like this to be as successful as it can be, communications around it have to be continuous, robust and brilliant. So it's, I guess, some reassurance around that, the plan around that. And then also some, I wondered if you just had examples of places that were further advanced than us in this way of working, and what are the key things we can take from places that are doing it well already, if they exist.
Right, I've got Chris and I've got Rob. So Rob, do you want to go first about...
Two quick points. From a snapshot that we did last autumn, and I think it was included in Zoe's report last time round, we're probably supporting somewhere around about 10% of the population of Plymouth in terms of the wellbeing hubs, in terms of people going through the doors. It could be higher than that. Whether they're absolutely 100% the right people in terms of targeting and resources and to have I think there's more work we can do to continue to support the people that are coming through and do targeted work. And then the other piece, there was a point about marketing and comms is a huge issue for us, and how do you do that when you've got a diverse voluntary sector with its own communication strategies and needs, and how can we engage that? And we do now have our programme manager for the Wellbeing hubs, and over time, hopefully, we can build on that. And we do have communication, marketing communication as part of our emerging business development plan for the Wellbeing hub. So hopefully, we will be able to tackle that. But we do need to certainly raise the profile of the organisations, and I think so many. I mean, I drove past the Manmead Wellbeing hub for about 4 years when I first came to Plymouth. I thought it was a sports centre or something. I didn't realise it was Improving Lives Plymouth, and it was a wellbeing hub, and I could just walk in off the street and have a conversation. So yeah, we do recognise there's far more work that we need to do around marketing and comms.
So I was just going to pick up the point about learning from best practice and where else is doing this. So it's sort of, as part of our development of this, we're doing a lot of work in terms of looking at where else are already delivering aspects like this. One example that often gets cited is probably by Bow Centre, Tower Hamlets, and actually where we've been out, some of the team have been out to visit that. What's really interesting, and I guess this comes back to the point about the assets that we've already got, is there are a lot of similarities in terms of some of the service provision that we have in the city. It's just about how we knit some of that together from a health perspective into that. And that's why I'm keen. I think whilst there's a huge benefit of us learning from where other areas have got it, we need to do what's right for the Plymouth system, and how we help those neighbourhoods to develop the things that make best sense, and then how we bring those services alongside that in the way that we move forwards. But because there's a national agenda around this, there's a number of networks that have been set up, and we'll continue to act as that bridge into those and understand where, as we learn more, we bring that into this space as well.
Thank you. Yeah, I think obviously if we can be working together about the comms, that would be really useful, because there are just so many services offered or accessible in the hubs that we need to be making sure we're getting maximum effect. Obviously, we've set budgets now for the coming year, but I think there is always room to be improving people's outputs and whatever, isn't it? If we can make sure that we can capture people early and work with them rather than them ending up at ED because of something, then it's got to be of value, hasn't it? And even just people being more content with life in Plymouth is always useful as well, because that we need to get everybody engaged. It isn't just certain people. I mean, if we think about Pop's work, about your work, about improving lives, you know, it's all there trying to knit Plymouth together. It's, what's that saying? It takes a village to raise a child or something. So you can imagine what you'd have to have for a city, but still. Okay, folks, thanks. Thanks very much indeed, Chris, for that. Obviously, it'll be interesting to watch and see what happens with the way that the neighbourhood health services go. There seems at the moment to be a big push, doesn't there, looking at neighbourhood things as far as the health services there. But I think the other thing, I think what we need to remember is it's not just the health service, it's looking at the well-being as well. And I think that's what we have to keep sight of. It is a joint thing. It can't just be health all the time. There has to be well-being generally, I think, woven in. So I'm asked to get you to note the contents and continue support and engagement in the development of the neighbourhood health services. Are you all happy with that? Lovely, no dissenters, excellent. Okay, which means we now move on to Ruth and Gary, and they're talking about the HDRC. Now I can never remember what that acronym is, so you're going to have to tell us again. All right, thank you.
Lovely, thank you very much. Thanks for the invitation to come and give you an update on this. And I am going to start by going through what it is and what we're trying to do with it. The first thing I'd like to just comment on is I can see the logos are a little bit small now that I'm sat this far from the screen. So I'm just going to reiterate that this is a collaboration in particular between Plymouth City Council and the University of Plymouth and Plymouth Octopus Project. So there are other people that are working with us on this, but just to reinforce, those are the key partners. Now, the HDRC stands for Health Determinant Research Collaboration. It's been funded by the National Institute of Health Research. I apologise for all of these long titles, but effectively, as you're probably aware, there is a research body that works traditionally across medical research and across mainly the NHS. And they are used to doing programs where, you're testing a new type of drug, doing randomized controlled trials, or perhaps you're testing a new type of hip replacement joint or something like that. So for many years, they would be working on things like that. And they then broadened out to start to look at some public health interventions to perhaps look at things like smoking cessation and weight management, those kind of things. But what they started to realise is, as hopefully we all know in this room, the wider determinants of health are the things that really set the way in which we live, work, grow, and eventually age, and have shorter lives potentially than other people. And so they wanted to understand more about these wider determinants of health, but they were aware that there was little what they'd call research and little understanding of exactly what intervention works. So by that, we have lots of correlations. So we know, for example, that people that live in wealthier areas will live for longer lives, but we don't know exactly what it is about that makes the difference. The truth is, it's probably a very complicated picture, which we probably know from our work. So the NIHR recognise that a lot of these wider determinants of health are shaped hugely by local authorities and their role in shaping a city. And so they wanted to work with local authorities in helping local government to use more of the evidence base that is out there, but also to help local government to develop the evidence base. So to understand more about what works in Plymouth and how could that be applied elsewhere? Will it work elsewhere? Can you just pick it up and apply it somewhere else? Does the Bromley by Bow model work exactly if you replicate it in Plymouth? And so they set up a very rigorous application process. We had to put in a sort of academic level grant application. And we were one of 13 local authorities in the country that were successful in our bid with, as I say, University of Plymouth and POP. And we received just short of 5 million over a 5-year programme. So our particular bid, the aims obviously were very much directed by what the National Institute for Health Research wanted, clearly, but it was around developing a learning culture so that we could learn from the work that we were doing, learn from others, and use that to inform decision making. And we're probably fair to say that we think that the council was doing that to a large extent as much as we could, and possibly it was underestimated how much councils were doing that, but we'll leave that to one side. Produce locally valuable knowledge. So one of our key priorities is what works for Plymouth, for the people of Plymouth. How do we make that work better and achieve more? Also focusing on things that are innovative and developing the evidence base and using, we talk about triangulating the intelligence that we get. So really understanding what is going on to as much as we possibly can. How is it working? And therefore, how can we apply things elsewhere? So method-wise, as I say, it's a collaboration. And so we have researchers in residence from the University of Plymouth who are now seconded in to work with us in the council. And their first role was to get out and be useful. And we do have long lists of things that we could talk about. We haven't compiled lists for this presentation, but happy to talk later. And some of that was about accessing the evidence base, helping people to learn, were there other areas that were doing work? Had anybody published on this? Particularly around helping people to evaluate. So the very simple things are very simple to evaluate, but the kind of work that we're doing is often quite complicated. So having some guidance on what are the kind of measurements you might make? How do you develop a theory of change? How do you then measure it? Do you need qualitative or quantitative data or both? Those kind of research methods are quite complicated. And we are working up from the kind of building relationships, doing those smaller ad hoc pieces of work, to developing those larger projects and really getting stuck in with a researcher working alongside council officers. We've had a lot of interest across the council, we'll mention that later. We're taking what we call a human learning systems approach. I think probably most of you in Plymouth will know what we're talking about here, and that is in my slightly simplistic way. Gary has more complicated ways of looking at it. In my simplistic way, we need to meet the person where they are, understand what their needs are, and understand then what's the sort of complicated, it is quite complicated and complex path to get to where we want. So, for example, I would love to make less people smoke in Plymouth. But I know that if I get somebody who smokes to walk through the doors of one of the wellbeing hubs, if the first thing we do is collar them and say, you're a smoker, you need to go on our 12-week smoking cessation course, that's not going to work. You start out by saying, what's important to you? Some of them might say, I'd love to stop smoking, and that's brilliant. In that case, they get the course straight away. Some of them might say, I can't sleep at night because I'm so worried about my child and the roof's leaking and I'm cold and I'm struggling to get healthy fruit and veg or something. And some combination of those things. So start with the person, and it's complicated. Lives are complicated, and sometimes if you try to boil it down to a simple equation, you completely lose the richness of the evidence. We've mentioned that as well. Yeah, and you know, this is difficult to do. It is very much not like taking a tablet and saying you take a tablet, you take a placebo, and let's see what the difference is in 12 weeks. It is far more complicated than that, and I think that's one of the things that we are trying to recognise. I would also say that our work is working both ways. So part of what we're doing is feeding back into the NIHR of some of the ways that they can be supporting councils to do this, as well as us trying to change and improve what we do. Gary's going to take over here.
Good morning, everyone. So, I mean, really, as it says, we've been, so there are now 30 HDRCs, and we've just been invited to bid for a further 5 years to go to 2032. We are one of the HDRCs that is overwhelmed with asks, which is a great position to be in. Many of the other HDRCs are struggling to engage. We think part of the reason for that is we're doing, all of our research must be generated by people doing the work. It's not academics coming in and saying, I'm really interested in X and Y, can we research that? So we've prioritised a number of projects via the kind of DMT and directors. They've helped us prioritise the projects that they believe will bring the maximum benefit to their particular issue. We're kind of collaborating with other coastal HDRCs. That was part of our bid. As many of you will know, many of our coastal cities face similar problems, and there's stuff we can learn. I'm happy to see we're working with all the organisations in the room on something or other. So we work with the NHS, we work with the VCSE. The VCSE are a key partner in the HDRC, so we see our view of the VCSE is, in recent years, they've taken on more and more work that used to be done by statutory services, and we see them not as a tool to do the work we used to do, but rather as a kind of living, breathing partner with an important voice and important contributions to make. We're also teaching and spreading innovative approaches through publication in peer-reviewed journals. We have a number of those, but also by engaging with the LGA. So we're doing lots of projects with the LGA, sharing stuff with the LGA to spread these innovative approaches and also to steal innovative approaches from other areas. We love a bit of corruption and theft. Do you want to do that? Yeah. So some of our challenges, as really Ruth has articulated, the traditional way of doing research for the NIHR and for health services is largely around double-blind randomised controlled trials. They are really pretty useless for social processes and health processes. So our researchers are developing new ways of developing research which is relevant and useful for our situation. Some of the challenges we've had initially were getting people to engage because of the legacy of austerity and fewer staff doing more and more work. Some of our early projects, we were able to demonstrate we can help people decide what things to stop. where they're duplicating and how they can work more efficiently. And that kind of through the bush telegraph, that's meant lots of people coming to us because we're seen to be useful. Do you want to go? Yeah. So a couple of examples. So this is an example of an evaluation. So Plymouth has this unique forum that we set up, me and Public Health and the adult safeguarding team. And the kind of genesis of it was rooted in research, learning from serious case reviews, domestic homicide reviews, and from a big co-productive exercise the council did when it was pooling budgets with the health service. And it's really a forum of last resort, so the most risky, most complex people in the city, when everyone is at their wit's end, they get referred to this forum. And it's a forum with commissioners, practitioners, managers. And the idea is for everybody to be creative, to think outside the box. Many of the people that use our high-cost services straddle 4, 5 or 6 service silos. So they might have 4, 5 or 6 workers, none of whom talk to each other, none of whom coordinate their work. So this is a place where they can all come together and discuss the case in an open way and come up with something innovative, creative and bespoke for the person. We were asked to evaluate it. There have been 248 cases since it started. In our sample of 100 cases, one of the really striking findings, there are a number of really striking findings, was the fact that there were no avoidable deaths. So these are the riskiest people in the city, and yet in the 9 years it's been running, there were no avoidable deaths in this cohort. So we thought that's a really interesting thing. We need to understand why that is. We stepped outside of the 100 random cases, looked at all 248 cases, and essentially in 9 years there have been 7 deaths related to the reason the person was referred to Creative Solutions. So less than 1 death a year. Last year in the city, there were around 70 deaths, avoidable deaths, so people with substance misuse, suicide, alcohol. So that's a really remarkable finding. Deaths are really expensive, apart from being tragic events. One of the other really kind of key findings was how much staff like going to this forum, where it's very collegiate, they feel very connected, it helps them manage risk. Very often, there's no concrete action taken other than reassurance of the worker, you're doing the right thing, or we will help you do that thing. And that kind of gives them the energy to carry on and persist. But they are also finding these really innovative and bespoke solutions for people. And they kind of really value that it's a place where they're allowed to be kind, to be creative, to be collegiate, and to kind of do the right thing. The next example is the ecotherapy project. So some of you will remember the Green Minds project, which was a big European funded thing where we did about 1,000 appreciative inquiries in parks and essentially this is about children on the CAMS waiting list. So children with autistic spectrum disorder, ADHD and other kind of neurodivergent conditions, where they come for 6 weeks to spend time with a worker from CAMS and with natural infrastructure staff at Poole Farm to experience a variety of things. What happened was we looked at the research around what's important to the parents, the families and the children. Things like they have no friends, they have no kind of connection, the parents feel isolated, all those kind of things. And as you can see, this has been published recently in a peer-reviewed journal. There were really, really good outcomes on all of the things that the research identifies as issues for those families and children. So it was kind of proof of concept. And the hope now is that this can be a mainstreaming thing. It's absolutely changed the lives of the parents. If I showed you the appreciative inquiries, you'd be horrified at the lives of the parents and how much they value this and how much it's transformational for the family.
So we've given a couple of examples there because those have gone off to be peer reviewed and published. obviously, it's equally important to understand when things aren't working. We've given you 2 examples of things with some positive outcomes, but it's equally as important to understand that as well. So our research topics across the council are fairly widespread, as has been said. And some of them do take a little bit of time, obviously, to work alongside the council to have the whatever the intervention might be take place, and then to do the evaluation and write it up. So we were always expected entering this HDRC that we would kind of have a somewhat exponential, nearly, probably a bit of an exaggeration, trajectory where it would take a little while to embed the researchers, to build the relationships. And we now feel that we're definitely on this upward plane where the kind of approaches are beginning to reach the limits of what we can actually offer, which is fantastic, enabling us to prioritise a little. The big opportunity we have is that the NIHR have understood, if you like, that this kind of work takes more than 5 years. And they are talking about extending the contracts for another 5 years. There will be a process to go through, and we don't yet know how certain we are of getting funded again, but obviously we are positive. And in a couple of weeks' time, we have the NIHR coming down to visit Plymouth to hear a bit more about the work that we're doing. So thank you.
Thank you to both of you for coming and telling us what you've been up to, and it's certainly fascinating. I mean, from listening to Gary, well, probably 12 months ago, sort of talking about various bits and pieces, it's really developed. And certainly having visited Pool Farm recently and heard of what they've been doing down there, it was absolutely fascinating. And I mean, Jemima and I didn't end up going on the tour, but I certainly know the other people that went on the tour thoroughly enjoyed it and could understand the positivity of it. The one thing that did worry me was Max the Axe, who came every Monday and learnt axe work because he would not engage in school, etc. But he had this fascination, so they were able to work with him. And you know, when I sort of couldn't quite get my head around that, the sort of this, but anyway, it's positive, and that's the main thing, isn't it? And it's that engagement. So I just find it mind-boggling the way that you can work out what people want and do it specifically for an individual, and that is what is important, isn't it? It's them feeling important as well. So that's great. Any questions, any queries? Jemima?
It's not a question, just to add to, I met a group of young people at Pool Farm who were taking part in those activities, and it's just, you know, transformational really for them, and then obviously the knock on then for their families. And I just think it's brilliant work. It's really thinking outside of the box kind of work, and using our kind of assets, natural assets, to really influence people's well-being and consequently their futures. I find this work deeply impressive anyway, but yeah, I just think it's fantastic.
Anyone else? No? Right, well, you've stunned them all. So I'm asked to ask you to, the Health and Wellbeing Board is asked to note the progress made to date and encourage ongoing collaboration between the HDRC, Plymouth City Council, the University of Plymouth and other stakeholders. It's a crucial partnership, this, I think, and it just gives us so much information that we can guide policy and commissioning decisions to improve the health outcomes. So I think it's essential. So I'm hoping you'll all back it, folks. Yeah, no dissenters. Both of you, thank you very much indeed for coming along. Much appreciated. Okay, Kamal, come and join us at the table. Welcome.
Thank you, Chair. Thanks for having me.
And the floor is yours.
Excellent. Thank you, everyone. So, yes, I'm Kamal Patel. I'm a consultant in public health at Plymouth City Council. And we're talking today with the annual update on suicide prevention. So, you've got the papers, but I'll just do a quick run through the slides. So, think that's working. Okay, so so this is, as I said, the annual update on suicide prevention to the Health and Wellbeing Board. So the accountability for suicide prevention activities and plans sits with the Health and Wellbeing Board, and I do an annual update. So I'm just going to do a talk around and then a bit about the background, some of the local data, updates on the local data, the system that we have around suicide prevention in Plymouth and wider in Devon, the activities that have taken place this year and the priorities for next year, and then the recommendations to the board. So firstly, I'll always caveat a talk on suicide prevention with a comment that it's a difficult topic. I don't know everyone here or online's personal history, so if anyone obviously has difficulties or any issues talking or being here, then please feel free to take time. And there's also links to support there. So suicide is the act or instance of intentionally killing oneself. So only a coroner can determine a suicide following an inquest. In suicide prevention work, we talk about data and numbers to inform the work that we do, but we're always mindful that we're always talking about real people and tragic experiences. So please do bear that in mind when I do talk about some of the data, because we know that suicide has a tragic and devastating loss for that person, and then their family, friends, and the ripples go far and wide and are lifelong, really. So again, the causes of suicide are really complex and individual. There's very rarely a single cause, and there are risk factors for suicide, and those risk factors often reflect the wider inequalities and economic factors in our life. We also know that although the impact of suicide is a very personal one, it does have a huge cost to society as well in terms of I've got the figures there. And a really key point about suicide prevention is that 70% of people who die by suicide, this is both nationally and in Plymouth, aren't known to mental health services in the year before they die. So this is about a whole, suicide prevention is everyone's business. It needs to kind of be thought of that way, because it's not just a mental health services responsibility. And suicide can be preventable, and we can learn lessons from suicides to try and prevent future deaths. So this is the data for suicide rates in Plymouth over the last 20 years or so. So I'll just take a moment to go through this. So the solid lines are Plymouth and the dotted lines are national, so England and Wales. Sorry, just England in this case. And then the top blue line is males, the bottom red line is females, and the middle green line is an average of all persons. So you'll see here that the suicide rate in Plymouth is generally in line with the England average. So at the moment, the rate is the number is lower, but it's not statistically significantly different. So we'd call that in line with the England average. As you see previously, in kind of the mid and late 2000s, the suicide rate in Plymouth was significantly higher than the England average. The other caveat to this data is that this is based on registration, so coroner registrations of death post-inquest. And we know that in the last few years, the length of delay between a death taking place and the registration of the death post-coronial process is quite long, but it's longer in Plymouth than it is for England. So the median delay for deaths registered in 2023 in Plymouth was 566 days. In England, it was 199 days. So that affects this data, because it's likely that the rate shown here in Plymouth of official statistics is lower than reality, because there's been a longer delay, so the registration hasn't come through yet. So it's important to kind of note that it is a positive that we're below the England average. Part of that reason, don't know exactly how much, is because of the delays, and there is work taking place in the coroners to reduce those. So there's been increased capacity this year. So it's it's likely that they'll be able to do more inquests this year, which actually means if I'm here next year talking about this, it's potentially the rate will go up. But again, it's difficult to determine. We'll have to unpick the cause in terms of registrations and the delay. So I'll obviously present that next time. Okay. So what is suicide prevention? So the work that we do is really broad. It encompasses all and almost everything that's to do with well-being is suicide prevention. So any measures to improve population emotional health and well-being through the wider determinants and core determinants of health is going to have an impact on suicide prevention. Support for people with mental health issues, be it from early intervention all the way through to the crisis care, that's suicide prevention. And support for people who are bereaved by suicide, again, that's suicide prevention. So it's really, there are some activities that are really focused on suicide, such as bereavement support and crisis support. But then, all the other work that the Health and Wellbeing Board do, work we talked about today, all of those core determinants of health are having an impact. So it's really showing the health of the wellbeing of the population. So the preventative approach needs to take into account that complexity. And as I mentioned, it's no single organisation or person's responsibility for suicide prevention. And it's everyone's business, and it needs that whole systems approach to do that. Because this is a public forum, I always talk about how we talk about suicide. So we know that that it is hard. It's a difficult topic to talk about. As I said, you don't know everybody's personal experience. However, there's no evidence to suggest that talking about suicide will put thoughts into anyone's mind if those thoughts aren't there already. And actually the converse is true. If someone is thinking about suicide, asking them directly about suicide can actually relieve that internal burden if approached sensitively and compassionately, and actually enable them to seek help. And it's unfortunately it still is a stigmatized topic, and we know that any stigmatized topic reduces people seeking help. So anything we can do to reduce stigma means that more people are likely to seek support for themselves. So I've just put in there a few kind of words around. So worrying about language shouldn't stop people talking about suicide, but there are some thoughts that I put down there that are useful to think about when we are talking about suicide, and sort of phrases to avoid, and then alternatives. And I just think it's important that I mention that each time I talk about suicide. So talking about the system, we have a suicide bereavement service which is funded by NHS Devon, and they are commissioned across the whole of Devon and provide support for anybody, adults and children, who are affected by suicide for as long as they need it, and they will support anyone with historical or recent suicide. So you could be bereaved 30 years ago, and if it's impacting you, which it might still be, they will support you and support you quickly. There's no waiting lists at that service. Suicide prevention training is a really key cornerstone of the work that we do, because it's about enabling people to feel confident and competent to have a conversation with somebody, know how to approach that, and then know how to support them next. So Live Well are a commissioned service locally who do different levels of mental health and wellbeing training, all the way up to kind of applied suicide intervention skills training, which is the assist course people may have heard of. So we have a suicide prevention strategic action plan in Plymouth, which is part of your papers, more for reference than for anything, but the plan is based on the national strategy. So there's a national suicide prevention strategy which identified 8 priorities, which you can see there. And so we, as local suicide prevention action plans, base our plan on the national strategy, because the national strategy is based on the most up-to-date research and evidence and data. So that's there. We also have a specific children and young people suicide prevention action plan, working through the Children's Safeguarding Partnership. And again, that is informed by the national evidence and research that's done in deaths of children and young people, and those priority areas identified through those national works. So looking at 2024-25, some of the key activities that we've undertaken. So we've used some one-off NHS England funding to organise grassroots suicide prevention small grants. So Plymouth Octopus Project administered a really collaborative process, which I could talk about for a while, I won't now, to distribute and work with grassroots organisations who are supporting people or planning to support people who are at risk in the risk group for suicide. And so trying to go really upstream, but focusing on those risk factors as well. We've undertaken a audit of coroner's files, so post-inquest, reviewing the inquest results to identify locally risk factors and details of those deaths to inform learning and plans going forward. One of the emerging themes in suicide prevention is around the link between domestic abuse and suicide prevention. So we have worked with the colleagues in the council around violence against women and girls agenda to organise a suicide and domestic abuse conference at the end of last year, which was really successful, attended by lots of delegates from across Devon and Plymouth. We've also been raising awareness on suicide prevention on Suicide Prevention Day with an event in the city centre. And last year, I also delivered a talk to counsellors on suicide prevention in terms of through counsellors' casework and their day job, they potentially can come in contact with people who are approaching or in crisis. And so I gave a talk, and there's a guide that got sent around as well to counsellors around that. So looking forward to next year, so some of our key priorities, we are working to improve our collaboration with Devon, across Devon ICS in terms of joining our suicide prevention activities together. So I'll cover that in the next slide in more detail. We're working again with Plymouth Octopus Project around men's mental health promotion in terms of trying to build that collaboration between different men's groups in the city so that they have that collaborative advantage, that extra support, that kind of greater awareness. We're continuing our young children, young people suicide prevention work, and we're also updating our training programme, Deliver Through Live Well, to make it as relevant and up to date as possible. So one of the recommendations in the report is around working as a Devon ICS on suicide prevention. So as I mentioned at the beginning, the accountability for suicide prevention is through health and wellbeing boards. In Devon, we have 3 health and wellbeing boards. And so this recommendation is around how we join together as local authorities and areas to build on that coordination and collaboration. So all 3 areas in Devon will use a national suicide prevention plan as their framework for the action plan. So the action plans, when we've reviewed them, are actually relatively similar. One of the challenges we faced is because suicide prevention is so broad, we have to work with multiple partners. We work with NHS, for example, the police, highways, rail. Many of these organisations struggle to engage each of us individually because they have to do something 3 times, or they work over a broader area, including Cornwall or the whole southwest, multiple times. So one of the thoughts about coming up with a Devon ICS plan is that it would enable greater coordination and collaboration with those kind of county-wide partners so that we don't duplicate our efforts across the region. It would also, we've had the talk about the joint forward plan from Devon ICS today, and suicide prevention is a programme on that, so it also kind of fit very well with with the joint forward plan for NHS Devon. I think the key point is that we would still maintain our local engagement. So the local suicide prevention partnership that I lead in Plymouth is a network of multiple organisations, from VCSE, statutory services, and interested individuals even. That would be maintained, and that would inform the Devon plan. And also the other part of it is that we'd still maintain our accountability to the Health and Wellbeing Board. So we'd have a shared plan, but it would always come to the Health and Wellbeing Board as this item annually. So so those are the two recommendations from the papers. So that's about reviewing and feedback on the suicide prevention activity undertaken this year, and the plan going forward in terms of that ICS level work. Thank you.
Thank you, Kamal, for bringing this to us. And I think it's an excellent idea to have something that's Devon-wide. I think it makes, as you say, it makes life a lot easier for a lot of partners, knowing where they're going, don't they? That would be useful. And again, the presentation you did for councillors last June, July time, somewhere like that. I can't remember quite honestly, but that to me was an essential thing. And I think what I would like us to do is to make sure that we put that within the council learning cycle. And even if we have no elections technically this year, I think it needs to be repeated. And I know it's online for people to watch, but I think it's sitting around a table and being able to ask questions if you want to me was quite essential, and making sure that people understood what the phone numbers were for and when to use them. So that would be my thoughts, Elliot, if we can organise that. You know, if we have to wait till August, September, then so be it. But I think if we can get something put in the diary, it would be useful. Any questions, any queries? Patrick.
Thank you, Chair, and echo your thanks to Kamal. Thank you for the presentation. In terms of stigma, you know, society has moved on a long way from, you know, when I was a sort of a youngster. How do you assess stigma? Because, you know, obviously we're in our own little bubble, you know, in our own sort of areas of work and society, and I sense that, you know, these things should have moved on, but you're saying there is still stigma around suicide, which is, you know, it's a terrible thing, isn't it? Because generally people are in a bad place, hence the reason why they take their own lives. So I don't know if you could expand a little bit more on, you know, on stigma and how bad it is, because, you know, all those of us who are a certain age, you know, you go back 40 years, it was very much, I would perceive it to be very much more an issue then than it is now. So I'm concerned that still here that stigma does exist around this area. And just so I'll note the delays in registering through the coroner's service. And I don't know if anybody can tell me who the cabinet member within the council is for the coroner's service these days. It'd be useful to know. Sally, is it? Thanks. So just on the stigma bit, Kamal, I don't know if you could just expand slightly, please.
Yeah, absolutely. I think there's always a journey. So I think it's improved. My impression, I wasn't kind of, I guess, you know, it's difficult to say fully, but, you know, it was a criminal offence, you know, years and years ago in the past. It's not, but there is still that hang up from that, especially, you know, thinking about the language around the word commit, which is used, you know, I hear relatively frequently, and it's not anybody deliberately using that language. I've never sensed it's never that, but it can have an impact on people. So it's a very subjective thing how people experience stigma. Actually, the research on some of the language around suicides, when you've asked people who are bereaved by suicide, the word, it's actually quite a divisive one. Commit. Some people don't mind it at all, and some people have really strong aversions to it. So in that sense, that person might feel more stigmatized than than others, and so it's a bit of a variation. Whereas most people agree that language around kind of just, it's only attention seeking is it still happens. I think it happens less, but it still happens. So I think it's a continuous journey. I agree. It's almost certainly significantly better than it was 10 years ago, 20 years ago, 30 years ago. But there's still a journey to go on.
Yeah, can I just come back from a sort of public health perspective and trying to educate everybody about these things? Is there something more that could be done around people's perception and trying to do further education on that? In the course of your work in the coming sort of 12 months or couple of years.
Yes, absolutely. So that's one of the reasons why the training is so important, and putting out credible and useful information. So obviously the work I did with the counsellors. Not that I'm saying that counsellors would necessarily have an issue, but that's one aspect. It's about just talking to people openly about it, so they can ask questions. I don't like myth busting generally, but some people might have perceptions that are better to talk to rather than I'd rather someone ask me and I can kind of give an appropriate answer than not to worry about it and not to ask. So me going out there talking to counsellors, that training programme that Live Well run is really important, and we work with organisations who might be more likely to come into contact with people with a higher risk of suicide to make sure that training is promoted in those workforces in particular. So that's the kind of approach that we will take in general.
Yep, Stephen?
So one thing that you haven't mentioned, but I think is really pertinent and probably addresses some of the points, is that broader work around how we look at mental health, but also how we engage with not only social media, but some of our printed media. So some of the things that happen to be printed in local media is not very helpful or conductive, particularly when you're looking into the agenda that is suicide. So we are looking at that as a Devon space to try and tackle that, because one, it is about the language we use, which Kamal's highlighted, but also it's around trying to reduce the sensational advertising of potential suicide spots. The media is very good at giving a lot of information, which isn't very helpful, because if people are in a crisis mindset, then effectively what some of that local media are doing is advertising places which may be inappropriate to advertise. So we are working in the background to try and address some of those issues with local media outlets. Thanks.
And certainly Cabinet have been concerned about delays and the coronal process, etc. So certainly I'm very happy to again speak with Councillor Hayden and with the Director of Public Health to see what we can do to make it more timely, shall we say. Let's take it that way. So we'll see what we can do. Kamal, do you want to come in there?
Yeah, just to say that the delays are stark for Plymouth. They're the fourth longest in the country if you look at unitary authorities. There is a reason for that, which have already taken steps to remedy. So previously we had a coroner for South Devon and Plymouth, and so where their workload was particularly high, that meant that other work didn't get done. So for example, the Kiam incident resulted in a significant loss of capacity within our local coroner to do this work, which is why we saw significantly increased delays. Now, as a joined up process with Devon, that enables, if one coroner is taken out of mainstream work to do this particular thing, that means there's still other capacity to pick that up, which wasn't there previously, and they've increased the capacity overall. So some of those measures have taken place. It's just because the official statistics are deaths registered in 2023, which is a couple of years ago now, that we haven't seen those in the official statistics yet. So I'm hoping that's why next year we will. The caveat being that might increase our suicide rates because of the catch up. So.
And the other thing is to say, although Exeter is being classed as the senior coroner's office. In fact, the conditions of that happening were that Plymouth, anybody that needed to attend coroner's courts were given that option, and we're making sure that the paperwork shows that people don't have to go to Exeter, because obviously you're thinking about transport costs, etc., except when you're in a bereaved state. So it's so we have been pushing to make sure that the letter says Plymouth for Plymouth people, and I think that's what's important. And equally, you may well find that somebody, if some other family would prefer to come to Plymouth than go to Exeter, even though they might live Exeter or past Exeter. So I think, there needs to be care and consideration given to where the coroner's courts are held, etc. Okay, Laura?
Thank you very much. I really enjoyed that. I didn't mean to say enjoy, but you know what I mean. Stigma is, I think, very interesting. In your common risk factors list, you've got alcohol and drug use. Stigma is a big issue in people seeking certainly medical help for alcohol use. So we see it up in the trust in hepatology, very much the stigma around use of alcohol. So I wonder if there's an opportunity for some research projects between public health, if you're not already connected, and our hepatology research groups, research group, and maybe some other risk behaviour type of places where you see it borne out in the physical illness. If there's something that could be done looking at the earlier routes, so prevention, I'm thinking about.
Yes, thank you. That's a really good question, and there is work being undertaken there. I'm happy to kind of maybe discuss that as well and see what else can be done. But we know that we are in the process, as almost completed, have done an alcohol hospital needs assessment. So looking at people who are in hospital for alcohol and making sure that that process in terms of that community treatment is available. Our drugs and alcohol treatment services have, in the last year, increased their capacity to deliver alcohol-specific treatment quite significantly, from almost nothing to a whole team for alcohol. So that works really closely. And the other element is we have in my team, I have someone who leads on what we, Gary mentioned it earlier, what we call avoidable deaths. So looking at people who die by suicide, but we also know people who die by, there's a significant overlap with drug deaths and alcohol deaths, and sometimes a drug death is called a suicide, sometimes it's not. It depends if the coroner has enough evidence to say it's a suicide, but we'll never really know what is in someone's thoughts before they die, if there isn't, for example, a note. And so joining the learning from those processes and working closely with our drug and alcohol services around suicide prevention is currently key, and we have good links with the alcohol liaison nurses in hospitals as well. Yeah.
Oh gosh, yes, thank you. Adverse childhood experiences, is that another area that you're interested in delving into? Or could that be? I'm thinking in terms of, could we be looking at data and starting to predict or identify people who may down the line in 30 years' time be at risk of something? Are there smart ways we can be using technology to actually start to determine where preventative techniques or tactics need to be put in place?
So very good question. It's really, really, really difficult with suicide prevention when you talk about risk factors. So I've mentioned risk factors, and it's in the group, because how you present the data can come with very different pictures. So for example, take average childhood experiences or say self-harm, for example. We know that around 40% of people who die by suicide have previous history of self-harm. So it sounds quite stark. It's quite, we should be focused on people with self-harm, which we do, because it's a significant risk factor. But when you take if you take the cohort of people who self-harm, the number of people who die by suicide within that is actually really, really minuscule. So If you look at it one way, it sounds really stark. It's really tricky. The other way, to actually, you would. I don't think I would ever be able to predict with any level of useful certainty or individuals who would die by suicide, which is why suicide prevention takes place at this local authority public health view, because it's really talking about that population level approach, because it's just too hard the other way around to identify individuals. But you can work with workforces who see people with risk factors to enable that suicide prevention as part of their job and work, so that when they do come across someone who might be at risk, that they can support them.
I think, Laura, the conversation can continue outside of this meeting. I think that would be quite useful.
I think so too, thank you.
Okay,
Yeah.
I'm going to take one last question from the Vice Chair.
Thank you. It's a very interesting report. I'm possibly one of the only people here who can actually remember that suicide was a crime. And it's, in fact, from what I can recall, it was very rarely recorded as suicide. It was usually a cry for help. And so maybe it's in the language that we ought to think about if we're trying to avoid the stigma of suicide.
Yeah, absolutely. And that's 100%. That's why I've mentioned that the language is really key to making people feel like their thoughts are okay. There's not something wrong with them, and that will enable them to be more likely to seek that support. So I do think language is key. And if anyone approaches the conversation sensitively and compassionately, they'll use the right language. Or it'll be interpreted in the right way. It's not necessarily the word that's used, it's how we talk. So, and that's kind of one of the key things that I want to put across.
I don't know if you've got any statistics about sort of the number of people that were actually registered as having suicides prior to the act and after the act.
Ooh, I don't. I wonder if anyone does. Yeah. I can have a look.
Well, thank you very much for bringing this report to us, and it is essential that we see this report yearly to keep us aware of what's happening within our population. I've got some recommendations again that the Health and Wellbeing Board is asked to review, feedback and comment on the suicide prevention activity undertaken in 24-25, which we have done, and the suicide prevention strategy action plan is noted as well. So thank you for that. And then secondly, the Health and Wellbeing Board is asked to support the development of an ICS level suicide prevention action plan, which seems very logical, I must admit. And as I say, what I would like to do is to make sure that we're watching what happens with the coronal process and make sure that there aren't any untimely delays in the process. So we'll do that. Okay, thanks folks very much indeed for that, and thanks Kamal. We will see you again very soon, no doubt, on something else, but still, thanks, bye. Right, how are we doing with Rachel? Is she around?
Through you, Chair. Rachel hasn't managed to join us yet, and I'm aware she's in a busy meeting all day and needs to dip out for this meeting. So I would suggest we move on to tracking decisions and work programme and come back to Rachel's item when she manages to join.
Agree, right, tracking decisions.
Thank you, Chair. So there's been quite a considerable update to the tracking decisions since the publication of the packs. So I'll read out the updates to members today. I'll also circulate them to you after the meeting. So the first one from the last meeting related to asking the Director of Public Health to liaise with the University of Plymouth in respect of research projects. Been informed that discussions are underway between the University of Plymouth and PCC colleagues. I don't know if there's a further update to be. Laura's just left the room. We'll move on to the next one, and I'll circulate any updates further to that by email. So the next one was the Dental Task Force to consider gaps at the next meeting, gaps in dental placements and workforce. There's a response provided saying At the Dental Task Force meeting of the 7th of February, workforce was covered in the ICB update and is a new area of focus for the Dental Task Force going forwards. The minutes state that with regards to workforce, there's been an investment of £300,000 into Golden Hellos with 18 approved posts and 2 filled. A local workforce group will be created by the ICB to understand the challenges in Devon and to consider initiatives to address them. So it looks like that one's very much been picked up at that meeting, and I've marked complete. The next one is agreed to circulate the Devon stakeholder dental briefing to board members, which are sent out on the 17th of February. And the others are as per your pack, both in progress. I'll take any questions. Thank you, Chair.
Patrick.
Yeah, thank you, Chair. Thank you, Elliot, for the update. So I raised, I think at the meeting on the 24th of July last year, around checkups at dentists. In order to close it out, and clearly it is an ongoing issue, so it will be in progress and remain in progress for a long time. But I'd like to know really from NHS Devon what the aspiration is for dentists to reintroduce checkups. So if they can't do it now, when are they going to do it? Because keeping it open forever is not the solution. So that was my ask at the time, and whilst I appreciate the response, I'd like to know what the deadline is, to mean that if you are an NHS dentist, a client, you will get a checkup and you won't just be pushed out forever.
Yeah. I think what's happening now is that there's a review, isn't there, about the dental service. I mean, I seem to, and I don't know where I've read it, but it's saying that the average adult doesn't need checkups except for every 2 years. That was mentioned. So I think at the moment the whole dental contract etc. is looking. I mean, we still need more dentists to do NHS work. There's no two ways about it. But I think the idea that everybody needed 6 monthly ones, I think research has shown that that's technically not needed. But my understanding is that all dentists are working as they should have been done pre-COVID. That's all finished now. It's just basically at the moment it's the lack of NHS dentists. And Tony, I don't know if you've had any more information about what's happening with the dental thing, but certainly the Dental Task Force is very much aware. It's getting the contracts and the contracts to be fulfilled with NHS dentists that is the problem at the moment.
Yeah, I think from what we've heard, it's that national contract debate and renewal that's going on at the moment that is kind of dragging capacity. At the end of the day, it's NHS dental packets of work that's undertaken. It's not an NHS dentist as such. It's a dentist who's private who will undertake that activity, and it's the contract that's kind of stalling that.
Okay, I think we've morphed this into two issues. So, I think you're absolutely right. The overarching issue of the contract is one matter, but where a dentist. So I think you're respectfully say you're wrong, Chair, because I'm an NHS dental patient and I've not had a checkup since before COVID. So I've had treatment, but I haven't had a formal checkup. So I think what I'm asking is if packages are being performed in the name of the NHS, we should expect that checkups are part of that regime. Now, irrespective of whether it's 6 months, 2 years, they're not certainly the dentist I'm at, there has not been a checkup. And whilst I accepted that it was impacted with COVID and we've had a period past COVID, it's not back to normal. And I think we just need to know as scrutineers what the reality is, not our assumptions, but what is the reality. And I would press again. I asked this question in July of last year. We're now in March of 2025. Those who are awarding the contracts need to know what they're being provided with by the dental contracts that they're commissioning. And I'd expect by the next meeting, Chair, that we have some data on this and we understand what the reality is.
I think maybe we get Melissa, I can't remember Melissa's surname, to the next next meeting, because by then things will have been firmed up, won't they, for the 25-26 year as to what the ICB are going to be contracting.
Yes, Joe, I'd agree. I wouldn't be in a place to comment on it really, but yeah, I think having Melissa here and I can have a conversation with her ahead of that, Councillor Nicholson, to raise that specific aspect to make sure we cover that off.
Okay, thank you. You know, we talk about preventative treatment. That is preventative treatment, isn't it?
Okay, right. Work programme.
Thank you, Chair. So on the work programme, the next meeting will be the 12th of June 2025, so the first one of the new municipal year. We've currently got 4 provisional items scheduled on there. The first one, the board needs to consider a response to a vaping motion on notice from City Council. The motion on notice essentially is calling for us to review and update our vaping position statement. So thinking an update on the progress since the vaping working group that the board undertook, and then consideration of the recommendation of updating that as appropriate.
And I think that probably needs to be in the light of the tobacco and vaping bill that will be going through Parliament. I think that may well be what I'm saying. That may need to defer that a little bit until we know exactly what that's coming up with. But Steve, if we can keep an eye on that and work with Dan and Dave about it, that would be useful. And obviously we need to add dentistry, dental checkups onto that now.
Yeah, through you quickly on that one, Chair. We were planning to bring the dental stakeholder briefing from the ICB to the next meeting, the one that we circulated, and if there's an updated version of that, so that would tie in with that nicely.
That would be very, very useful. Okay, now, what's the DCIOS annual report?
I don't know why they've written it like that. So that's the Devon, Cornwall, Isle of Scilly annual report. This is, what is missing is to tell you that it's the health protection annual report, which the Health and Wellbeing Board sees on an annual basis. So this is how the system has responded to health protection incidents across the last 12 months. So we'll reword the title of that one for everyone, really. Thank you.
Thank you very much indeed. Jemima?
I have spoken to Steve about the issue that I raised earlier around this kind of COVID cohort of children that I'm really concerned about, and we're going to do some work on that, but I don't know if there's a place for that, not necessarily for the next meeting, but for consideration of that work and partners' view on it, etc., for a future meeting.
If we can work out when would be the appropriate time to bring that, that would be useful. We can fit that in.
Yeah, so it might be actually ready for June. I know that Ruth's going to have a conversation with you about the data pack that we've created. If we can decide the next steps between imminently, then we may be able to bring something into the June meeting for discussion. So we'll update.
Right, Patrick.
Thank you, Chair. Just a very quick one. You know, I'll note in this next item some very good updates on new and improved facilities. Would it not be, when we look at the sort of work programme for the next municipal year, just have one item at some point during that year on highlighting all the physical improvements to the assets of the NHS in the City of Plymouth and anything of that nature, rather than just it drip thread through sort of the update reports? Because, you know, for instance, when I go up to Derriford, and I sort of sweep around as if you've got to turn left to Margin, it's a massive new building. I haven't got a clue what it is, but it looks a marvellous facility. It would just be good to educate us all as to what improvements are being delivered more strategically in a paper, rather than it, welcome though they are, rather than being drip fed into sort of updates as and when they come.
I think what we'll do is we'll work out how the best to do that is. It may not be appropriate to do it here. It may need to be a different one, either scrutiny or a separate presentation to all councillors, maybe. That's another thing to think about. But we'll work out how to do that. But Rachel's here now simply because she's one of our partners, and if she'd have been in the room, she'd have had the opportunity to say some things, but she wasn't. And thank you very much for your report. It was very informative. And the floor is yours.
Thank you very much. I'm hugely sorry that I haven't been able to be joining you for the whole meeting. We're deep in our business planning period, so I had to split my time today. But thank you for the opportunity for the partner update. I'm very happy to get feedback. This is a new style that we're doing these reports from members. If there's it covers the right kind of areas, or there's more that you would like to see, I'm very happy that we adapt. This is actually an extract from our Trust Board report that we have each month as part of the CEO update. And there's three things that I wanted to bring to Health and Wellbeing Board's attention, and I'll just briefly take the report as read, but just pull out a little bit of a focus on those. The first one is hugely important for both the quality and the outcomes for our population, that they have improved and timely access to our services, and you will more acutely know the challenges that we've had at Derriford in being able to meet those standards around urgent and emergency access. You will have seen in previous updates when I've been to this board, we've had a significant focus in partnership with Live Well South West around the delivery of a one plan, a series of new interventions that open up capacity, but also fundamentally change our model of care to support people in a different way. Those have been in phases of implementation from the summer and remain ongoing, but hopefully what you can see from the paper is a glimpse of how those are performing and what impact that is showing. I mean, broadly, and probably the most powerful statistic to tell you is that we, in the period of the last 2 months, we've been the most improved hospital in the country for our 4-hour improvement standard, and we are also the 10th most improved in terms of our 12 hours of patients in departments. Those are very two key objectives that with our regulators we are monitored on. There are many things that have contributed to that. Probably one of the most significant things that we know in terms of safety is how we decompress the department, so that we mean that we have enough space for our clinicians to be able to treat and our patients to be comfortable. We've made around a 2/3 reduction in our ambulance waiting times, those long waits of ambulance handovers. And we have dramatically reduced those that have been waiting over 8 hours to be able to be transferred from ambulance into the department because of space issues. And whilst we are setting an ambition for 0 over 8 hours as we go into the next few months. And we had a sprint focus, a quality improvement focus that has really geared on some of the improvements that we've made, and delighted that we are now fully opened on our acute virtual ward, and with our Live Well colleagues, we now have 57 community frailty virtual wards to support those with vulnerable needs in the community. And our work with Chris and Gary around the work around our discharge pathways, and particularly the people who are now being able to support more independently with support and reablement at home. We've seen that increase by 150% of the people we're now supporting home as opposed to into intermediate bedded care. Hopefully you've seen some of the news items about our X-ray car, a real innovation in the UK. We're one of only 3 systems in the UK that have our mobile X-ray car. Really good video there that hopefully you've been able to see from, and that whilst we've got more patients each day, we've got capacity to see than we're currently seeing. We are able to support 90% of those are able to be cared for at home with the X-ray with conservative management, either with advice from our acute GP service or with the ongoing support of our community urgent response team. The next focus of the paper, which I think what colleague was just talking about, is the new developments in terms of infrastructure. So we know we will still have some space deficits in the hospital with a growing population and with the improvements that we want to make in the new technologies that are available in healthcare. And that's why we are so delighted that we were formally named in the wave 1 of the new hospitals programme, which will see that new emergency care building with extra emergency theatres and greater frailty same day emergency care space starting to be to come to life. That's why you'll see the diggers on site and the site walk around that we've got for people at the moment. But we've started that and we expect that the building will complete in autumn 28 and then in the summer of 29 for the children's ED department that follows. The building that a colleague was just mentioning at the top of the site, that's our on-site urgent treatment centre, Dartmoor, and that is scheduled to open within Q1 of the next year. That will provide both our urgent treatment centre but also space for outpatients. And just picking up the question, what we have got, Chair, is some really nice visuals that describe all of the infrastructure that's going on in the hospital. We'd be very happy to share that following this meeting, but if you did all scrutiny wanted to see that with our estates lead, very happy to talk you through not just the estate itself, but also how the model of care we will adapt into that for our patients going forward. And then the final area that I just wanted to mention was the Plymouth Community Diagnostic Centre. Again, that's been fully funded and approved. Key part of our blueprint work. We're working with you on partnership in terms of how do we have the good assets in and around our locations, and particularly in the city centre. We know what that drives in terms of footfall and economic benefit. So great to see that that's now confirmed in the West End, and the significant increase that will give us in off-site diagnostics with that rapid access to diagnostics and care, and that will offer around about 91,000 tests alongside our other tests, and is due to be a major part of our infrastructure going forward. I'll perhaps leave that there, Chair, in bringing those few things to life, but very happy to take any questions. Thank you.
Thank you very much, Rachel. I'm going to press you on that Plymouth Community Diagnostic Centre. You've left us in suspense there. In our report, it says the centre is due to open in, and there's no other thing. So when do you expect that to be open? I mean, I think it's next year sometime, isn't it? But I don't know if you know roughly.
Yeah, I believe September. Thank you.
I think that was making sure we'd read it, really, sort of leaving out that date.
Yeah. I'll get that updated for you for the record, Elliot.
Thank you very much indeed. Any questions then? Oh, so, Tony, sorry.
Hi, Rachel. Thanks for that update. I've just got one query to do with the community diagnostics. In the report, you mentioned blood tests. Is that going to be additional capacity to Windsor House, where the phlebotomy service has moved to, or will the service move again into the city centre?
So we're yet to do the full capacity modelling to see whether we require both. That's just from what we're learning with the some of the new demographic changes that we've got and some of the new models of care. So it definitely will have phlebotomy in CDC. Whether we need then the satellite sites, not just at Windsor, we have them in East Cornwall as well. That's just the modelling that we still need to do. But there will be a presence at the CDC. That's correct.
Okay, thanks.
Patrick.
Thank you, Chair, and it's thank you, Rachel, for the update. Hopefully, I can speak for the whole board in congratulating you and the wider team on the sprint process of massive improvements in the turnaround of people entering the emergency department. So well done. You know, clearly that, from a citizen's point of view, has been a major concern for a long time, and I think all health professionals that have contributed to this improvement need a huge pat on the back for the work that you've done. So thank you very much.
Thank you.
And particularly, you know, allowing ambulances to be back on the road dealing with people is a major improvement. Just following that, though, obviously those improvements we all hope are going to be sustainable for the future. Is there anything else that's needed to try and ensure that they are maintained?
Yeah.
And you know, what are the risks of us not being able, or you not being able to maintain that significant improvement, please?
Yeah, that's a great question. And the first thing I would say is, on behalf of teams, they will really welcome that feedback. So thank you. Huge team effort, not just in Derriford, but with our partners. And I must say that I think the strategic partnership with local authority, Live Well and the ICB, we're an ecosystem, aren't we, in terms of supporting our residents here. So thank you for that. And we're not stopping here. So there are a number of things that we've still got to mobilise that means that we've got this better alignment between the right service offer for the people and their needs, and as far as possible we want that to be as close to their communities. So we aren't yet fully having all of the referrals that we should be having for our X-ray car. We're not fully open with our community frailty virtual ward beds, but that will happen by April. Our end of life capacity that we've opened up at Mount Gold, we're currently at 8 beds, but we grow that to 12 at the beginning of April. So there are a number of things that will still manage. And also this is against a backdrop of where we're over and above where we planned for the right level of activity this year. We've seen an additional 9% on top. So we've delivered that performance with a 9% growth in the number of people that are still presenting at Derriford, which was over and above. We are at the moment somewhat of a national outlier on that number. So what we're going to be doing as partners is going back round the understanding of the need there as to say what are we still not meeting the needs well enough for? Is it that we've still got a capacity constraint at the front door, and patients do need to be with us, because there will be patients that their needs are such they need to be with us, but how can we support them in the swiftest way possible? But are there some things that we are missing, so that we know we still have a high number of people presenting from complex life with drug and alcohol concerns? We know that respiratory presentations are still high, so we want to carry on the methodology, councillor, that we've approached to the one plan early in this year, to really focus on the need and co-designing with our clinicians, but challenging ourselves that beds aren't necessarily the answer. How can we invest more into the community, do more prevention where we can invest to support that demand in a different way? So we've definitely still got things to do. We still have improvements within the wards to make around how our process works, to make sure we're well communicating when people will be ready to go home and be discharged. But what I can reassure you is that the sprint type approach and the methodology and the quality improvement work with our teams, I think, has proved really successful for us in the how we do this, not just the what, and that's what we want to continue.
Thank you.
Thank you. Okay, right. Jemima.
Thank you. And I was out at the beginning of your report, so you may have covered this, but the number of people still coming who you're not sure why they're coming, or maybe it's not the right place for them. Are they people who've circumvented primary care largely, or is that part of the problem? As in, could they have seen a GP and then they wouldn't have come up to ED?
Yeah, if I'm honest, councillor, it's very difficult for us to make that judgment, because where we've done those types of surveys before, people may report that they have or haven't tried. So being able to validate that is difficult. What we've tried to do is take the approach to say, of the need that they're presenting with, could there have been an alternative they could have tried? So another area that we're focused on is that also we need to recognise that entering our urgent care system is really complex. There's probably about 15 front doors for people, whether that's primary care, 111, 999, our urgent treatment centre. That's quite difficult, particularly when somebody might be in quite a stressful situation where they're seeking support. So one of the new interventions that is going live literally week by week as I speak is we're working in partnership with the 111 provider, PPG, and with the ambulance service and our team here. And we've developed what we've called it's a single point of access. We're calling it our gateway hub, where actually where somebody might come into 999, or where somebody might be at a GP practice, or somebody might have gone through 111, there can be a call to that hub for the clinicians to have a joint conversation to say, well, you know what, for Mrs. Jones, actually, you might not know about it, but we've got this service here. Why don't you refer Mrs. Jones there, i.e. the X-ray car or community frailty virtual ward? But the hub is designed to give a bit of help and a bit of clinical and professional MDT to help support that. We are also continuing to do our audits at the front door to seek and understand why people either are they aware of those alternatives, did they try them? But I suppose I just put a bit of a health caution with that, is we don't always get the accuracy in those audits that mean that we can take those types of decisions on that basis.
I'm just interested in your comment that Plymouth is an outlier in this particular arena. So I guess it's really key to try to understand why that would be the case in Plymouth. And I welcome you taking a holistic approach to it. And I get people might not, in pain and anxiety might not be the most, reliable reporter of their route to that place. But
We are looking benchmarking and see if there's anything we're missing, because that's a kind of discipline with our insight we're trying to do. So working with Chris and the actually NHS England across the southwest to just take a look, is there anything that we've missed in that as well?
Rob?
Hi Rebecca, Rob Smith. I'm Chief Exec of Improving Lives Plymouth, a local charity, and chair the Wellbeing Hubs. And I'm just really interested, really, how we can. It's a common and general observation about how question around how we can improve engagement between the hospital and the community sector outside of formal commissioning opportunities around discharge, and also some of the strategic development work we're doing to align our services with Live Well. It's such a complicated entity to deal with in terms of smaller voluntary organisations, and how we can look to align our services with the needs presented in the hospital, and how we can improve that flow. Well, how we can improve the whole prevention agenda and then the flow through the hospital back out into the community. And in terms of, at some stage, to have some type of discussion around communication flows and information exchanges and how that works. Now, there might be systems in place that I'm ignorant of and that I'm not involved in that I could be, or colleagues could, but it just strikes me there is a degree of joining up or knitting that we need to do. Maybe it's something I can raise, actually, LCP later on today. So it's just a general comment, really. I just think to be able to have that joined up conversation between the hospital and the community, and I know it is on your agenda, but exactly how we do that, I'm just really keen to explore that conversation further.
Yeah, I mean, I would agree. I mean, that, communication is critical, and things change. We also recognise that, if for ourselves we've been on a fairly rapid pace of change in communicating that and how we get that flow right. So I was just about to say, I think the LCP and the forums and functions we've got around there is critical. But let's take that outside. I'm very happy to get your views as well, and let's co-design how we do that better, because it's on behalf of the people, we need to get that right and support that navigation as simply as we can.
Thank you. And Rachel, I think the Community Frailty Virtual Ward is an excellent idea. And I suppose really it's just, how do we get GPs to understand the value of it and make sure that they are referring people there rather than up to ED or whatever?
Yeah, great question. So Jonathan Cope, who is one of our GP by background and works as to be our kind of interface lead with primary care, has been in regular conversations through the LMC and the collaborative primary care board at kind of that strategic level. But we've also been undertaking some, we called them road shows with our PCN. So it's been a joint kind of learning event, an insight event with each of the PCNs. We've been out to visit them with Live Well and UHP and had a discussion about what the community virtual ward is, what some of the need is that we're seeing presenting, and talking about how that is a service for them and their patients. We very much see it in that way. I also would emphasise that the best way to help kind of make the case for why these services are so important is from our residents ourselves. We've got some lovely videos and feedback and outcome feedback from people. More the biggest thing people say to us is that they want to be in their own bed, whether that's their residential bed or whether it's their own bed. That's where they come from. We're at the hospital, we're only custodians for those individuals for a period of time. They are the custodians. They are that their home is where we need to be supporting them. So I think those cultural changes in how we view that is just as important, but having the feedback from people themselves and their wishes and overly communicating that, I think we found has been the most successful mechanisms.
Thank you very much indeed. That's really useful, because certainly it's a good way, isn't it, of getting that care, but as you say, in your own home. And certainly we watched the video at the last health scrutiny. Very, very powerful, very powerful. So thank you for that. Okay, folks, that's that. Rachel, thank you for joining us. I can
Pleasure.
appreciate you're busy, so we'll let you go back to no doubt another
Oh,
meeting.
lovely.
Take care.
Thank you so much for that conversation. Take care, everyone.
Bye. Right, folks, that technically brings us to the end of the agenda. We were going to have a little bit of a development workshop, but we think we're running out of time, really, aren't we?
Yeah, thanks, Mary. So yes, the plan for the last hour of the session was to really do a little bit of development work around the Health and Wellbeing Board, but